Morning, everybody. I'm going to give a slightly different talk from what I'd planned. Adam Merrids had asked me to talk through some new data. So what I'm going to go through now is the muscle program and where we are and where we hope to be. Critical care physicians are obsessed with death as an endpoint. Yet despite this, if you look around the world at the first world countries that report outcomes, crude mortality around the world is dropping. And in America, Australia, Hong Kong, and in Singapore, and of course back in the United Kingdom, your chances of dying if you're admitted to intensive care is probably only about 20%. Coupled with 80% survival, though, we have a rapid increase in critical care admissions. So what we're building here is a cohort of critical care survivors. This survival comes at a cost. Everyone in this room is of a working age, yet if we were to be admitted to critical care with a critical illness, 50% of us wouldn't return to work within a year. 30% of us would still need caregiver assistance in our activities of daily living. Margaret Herod showed this in 2003, almost a decade ago, and since then her work has been repeated by many groups around the world. I think we can all agree at this stage that surviving critical care is a public health issue. Muscle wasting and weakness is acknowledged by our patients and by all researchers as the single greatest contributor to this functional disability. Even worse, regardless of the definitions you use, muscle wasting is the most common secondary complication of critical illness. Despite this, we know almost nothing about the pathophysiology of muscle wasting. This is how I look at how people have muscle wasting. Healthy people have a normal amount of muscle. When you become critically ill, you lose muscle mass rapidly. And at some stage, you'll lose enough muscle mass that you'll cross this line. You'll no longer be able to function independently. You will become disabled. And if you survive, you've got a long road back to recovery. And Margaret Herod showed us that can take up to 5 years, perhaps even longer. The vast majority of research in this area is focused here, looking to change the trajectory of recovery and rehabilitation. My interest is here. We're working towards primary prevention, trying to limit the time our patients spend in functional disability. And that was the birth of the muscle study, the Muscle UK study, which was the vehicle for my PhD, which was supervised by my then 3 supervisors, Steve Harridge, Nick Hart, and Hugh Montgomery, who are now very close friends and mentors and collaborators in this venture. And we set out to understand the pathophysiology of muscle wasting and to develop tools to assess wasting and recovery. All muscle in all living beings is governed by the process of protein homeostasis, which is a balance of making muscle protein synthesis, and muscle protein breakdown. So when you woke up this morning, you were breaking down more muscle than you were making. When you had breakfast, the ingestion of protein switches on muscle protein synthesis and releases insulin, turns off muscle protein breakdown. And you cycle that cycles throughout the day. If you were to do exercise, you would increase your muscle protein breakdown because exercise is a catabolic stimulus until you were to ingest protein again, in which case you get a rebound rise in your synthesis. In critical illness, we didn't know how the various factors that affect muscle protein homeostasis interacted. And we didn't know whether muscle wasting was the result of decreased muscle protein synthesis, increased muscle protein breakdown, or an interaction between both. This process is governed intracellularly by the IGF-1 AKT axis. Where you can set off IGF-1 can activate AKT and set off the ubiquitin proteasome pathway, setting off muscle protein breakdown. Equally, AKT can be phosphorylated and set off a cascade of signaling, which is of anabolism, initiating protein synthesis, elongating protein chains and terminating the protein chains, which sends them off to be folded and starting protein synthesis. This is a gross oversimplification of the process because, in fact, there are other pathways that can interact with protein homeostasis, such as the NF-kappa beta pathways, the P10 pathways, and the myostatin pathways. So to understand all this, we needed to find a group of critical care survivors, and we set out to recruit prospectively patients who are intubated and ventilated, and recruit them within the first 24 hours of critical illness. They had to be intubated and ventilated. They had to be projected to stay intubated and ventilated for at least 48 hours, spend 7 days in a critical care environment, and they had to be projected to survive. And we recruited 63 patients to this study. These are the characteristics of our 63 patients. You can see they're of a working age, they're 54. They've got Apache 2 scores of 23.5, so they have a high risk of death. And despite this, the vast majority survived intensive care, and you can see that almost 90% survived hospital. So what we have here is a group of critical care survivors. And we performed serial muscle ultrasound on these patients on days 1, 3, 7, and 10, looking at changes in rectus femoris cross-sectional area and contemporaneous muscle biopsy, so we could look at histological cross-sectional area, protein DNA ratios, and immunohistochemistry. And we dovetailed in isotope infusions of leucine and phenylalanine, so we could look at actual rates of protein synthesis and protein breakdown. You can see here from the reference, this technique is not new. It was first described in 1973, which is before I was born. It's been used in the physiology sciences since then and in the sporting world. And this is what we saw. So on the x-axis of this graph, you'll see days from ICU admission. And from the y-axis, you'll see change in rectus femoris cross-sectional area, so the change in muscle mass, described as a percentage from day 1. And we separated our patients into the numbers of organs failed. And you can see that those people in single organ failure lost no appreciable muscle in the first 10 days, yet those in 2 to 3 organ failure lost something like 2% of muscle mass a day, and within 10 days they lost 20% of their muscle mass. If you had 4 to 6 organ failure, you lost even more, 26% in the first 10 days. So the sicker you are, the more muscle mass you lose. But as well as some changes in muscle mass, we saw changes in muscle quality. And over 40% of our patients had muscle necrosis. This is an example of one of our patients. So this is a muscle biopsy taken on day 1 from a 35-year-old UCL PhD student as she went into multi-organ failure. And the top slide shows you an H&E stain of normal, healthy muscle. It's polygonal in shape. It's got a nice deep purple color, and you can see these dark dots, these blue dots here, which represent nuclei on the outside of her muscle fibers. Yet by day 7, it had been replaced by this, a minor necrotic sample, where you can see that the outline of the cells is now blurred, the color is heterogeneous, which is pinky and purpley, and perhaps you can see there are a lot more purple dots. And this is a cellular infiltrate. We tried to characterize this by doing immunohistochemistry, and this is the same patient, the same time point on day 1 here, where there's a green laminin stain outlining the muscle and a blue dapple stain highlighting nuclei. And we added a red CD68 stain, which is a macrophage positive stain, which you can see is negative on day 1, but lights up on day 7. So within 7 days of critical illness, what we saw was that 40% of our patients had necrotic muscle and a macrophagic infiltrate. Moving on to protein homeostasis. This is the phenylalanine data. Again, on the x-axis, you can see day 1 to day 7, and the y-axis is phenylalanine flux. On day 1, you can see the muscle protein breakdown is higher than muscle protein synthesis, giving us a net catabolic balance, which I don't think would surprise anybody who works in critical care. But you can see on day 7, the muscle protein synthesis seems to rise, and muscle protein breakdown rises with it, continuing the catabolic state. So in our critically ill patients, we've got elevated muscle protein breakdown throughout. Looking at muscle protein synthesis, it's the same idea. X-axis is days from ICU admission, and the y-axis is the rate of muscle protein synthesis. Our patients have the same rate of muscle protein synthesis as fasted controls. This is despite establishing feed in 9 out of 11 of these patients. So feeding these patients on day 1 did not affect muscle protein synthesis. And by day 7, muscle protein synthesis began to rise to levels associated with that of fed controls. So saying that patients lose muscle mass rapidly, there's a loss in muscle quality, muscle protein synthesis is decreased on the background of increased muscle protein breakdown. To try and look for confirmation of this, we looked at the intracellular signaling pathways. And I said to you earlier on that what I'd shown you was a gross oversimplification. And rather than looking and reporting its individual intracellular signaling molecules, we looked at the activity of the network as a whole using a principal component analysis to see whether the activity within the family of signaling molecules paralleled muscle protein homeostasis. In fact, we found that this is exactly right. So activity correlated well with both muscle protein synthesis and muscle protein breakdown, reassuring us that what we'd seen seemed to be to hold true. Finally, we looked at clinical correlates of muscle wasting using our relational database, and we found an inverse relationship with PF ratio, bicarb, and hemoglobin. So the lower your PF ratio, the lower your bicarbonate, the lower your measurement of hemoglobin, the more muscle you lost. And an association with C-reactive protein and total protein delivered. So the higher your C-reactive protein, the more protein you gave people for nutrition, the more muscle wasting you had. In an attempt to generate a slightly stronger hypothesis, we use a logistical regression. We use a 10% cutoff. And in the COPD literature and in the heart failure literature, 10% of muscle wasting is considered to be one of the functional cutoffs for activity. And we found that the PF ratio bicarbonate came through still on the inverse associations, which allowed me to hypothesize that the severity of acute lung disease is causally associated with muscle wasting, which is a great hypothesis for me to have as a respiratory physician. So the conclusions from our first study was that muscle wasting occurred rapidly and early in the first week. It was most pronounced in multi-organ failures associated with age, acute lung injury, and systemic acidosis. Is the result of decreased muscle protein synthesis and a net catabolic state. And muscle necrosis and with a macrophage infiltrate is common. What I'm going to talk you through now is a variety of data at various levels of maturity, some of which is out to publication, out to peer review now, some still being developed. So I'd be quite interested in your thoughts and your questions. Earlier on I showed you that we're interested in the pathophysiology of muscle wasting, and that muscle protein synthesis is decreased on day one. This is reflected by the intracellular signaling. Muscle protein synthesis is a highly energy-dependent process. You need ATP to do this. Over a decade ago, Mervyn Singer, a good friend of mine and colleague, hypothesized that mitochondrial dysfunction occurred, and you had decreased biogenesis. Biogenesis being the turnover of mitochondria and the replacement of damaged or old mitochondria with new ones. And we hypothesized that, as Mervyn would predict, early mitochondrial dysfunction happens early and decreased biogenesis occurs. This would then be associated with a decreased use of substrates, and mitochondria burn fatty acids to produce energy, so fatty acid oxidation would be decreased. And the end result of this would be a decrease in ATP production. This is a very quick walkthrough of what a mitochondria does. So glucose and fatty acids get transported into the cells and get converted to pyruvate and acetyl-CoA. This is then funneled into your mitochondria, into the Krebs cycle, in the case of pyruvate, to produce ATP, and through a process called beta oxidation, where fatty acids are oxidized to produce ATP. This is coupled to the electron transport chain, which is the final production of ATP by generating a hydrogen gradient. And finally, the last bit we care about is biogenesis, which is what I told you on. It's the turnover of mitochondria. So mitochondria get old, they get damaged, and they then get replaced. And we looked at these three components. So the electron transport chain, by which ATP is produced, beta oxidation, where fatty acids are broken down to produce ATP, and biogenesis, which is the replacement of mitochondria. And we found over 7 days in 30 patients that there was no change in the complexes, so complex concentrations for the electron transport chain, implying that structurally the mitochondria don't seem to be affected. We found decreases in mitochondrial biogenesis, i.e. that these are markers that promote biogenesis, suggesting that turnover of mitochondria are reduced. And this is associated with a decrease in beta oxidation enzyme concentrations, suggesting that fatty acid utilization and substrate utilization is decreased. That's quite a lot of data. That's 180 odd data points over 2 days, and we over two time points, and we really struggled to try and understand what that meant. So a very good friend of ours at King's, Lindsay Edwards, who uses a mathematical model of mitochondria, funneled all these data into it to attempt to reduce all this into something we could understand. And he produced this heat chart. And the heat chart, the key to the heat chart is over on the left-hand side. So if you see something that's bright red, it's a log two-fold increase. I might draw your eyes to the bottom end. So log decreases are the dark green and the light greens. And the heat chart suggests to us that oxidative phosphorylation and the tricyclic acid cycle flux will be reduced, implying that the data we've seen so far would lead to a decrease in ATP production, as we would hypothesize. We went on to measure ATP in the muscle samples, and we found, this is some work done with my colleagues in Nottingham, and we found that ATP on day 1 was much lower than that of healthy controls and continued to decrease from day 1 to day 7. This is accompanied by a decrease in phosphocreatine and creatine. Phosphocreatine is a short-term donator of phosphate to ATP. It's used by sportsmen, bodybuilders, and athletes in an attempt to increase their performance, and it's been shown to work. However, in our patients, there seems to be a severe lack of this. And the combination of decreased ATP and decreased phosphocreatine suggests that the muscle is in an energetic crisis, and which leads towards questions of how we modulate this. That's as far as that story's gone at the moment, and the next stage is already to look at what happens to the substrates. So this is a picture of muscle and the red light is fat. And using NMR, we're starting to see build-ups of fat in our patients, so which you only see in obese patients and in the immobile and in high ultra-fit athletes. And we're beginning to investigate the effects of this fat on muscle. There's actually a term for it from the obesity literature. It's called lipotoxicity. And we're doing that with some friends of ours, again, back at UCL, Rachel Battermere, an endocrinologist with special interest in obesity. We're also looking at the adipokine and endocrine response to what we see as a toxic buildup of fat within the muscle cells of our patients. Before I move away from pathophysiology, I have to say that there are other components of the musculoskeletal system besides muscle, and that's the fascia and the bone. And I'd like to show you two observations, two stories that we've, again, sent out to publication that we haven't really developed. We're unsure where the story goes with this. And one is that in our patients with muscle necrosis, they have pathological evidence of fasciitis. This is some work done with Raoul Padke, a senior histopathologist at Queen Square back in London. Over here you have healthy muscle fibers with the black dots on the outside. There are 3 necrotic fibers here, which is a deep sort of reddish color. And in between is this gray area here, which in you and I, hopefully, would be completely acellular. And you can see the black dots within that. That's your fascia. That's this patient's superficial fascia, so in this case, the deep fascia, and it has a cellular infiltrate, which is entirely in keeping with what we see in fasciitis, in plantar fasciitis, eosinophilic fasciitis, and necrotizing fasciitis. We don't know the clinical significance of fasciitis in our critical illness survivors. Outside the sphere, fasciitis is associated with pain, decreased flexibility, and one might hypothesize that this would affect our patient's ability to mobilize and undergo rehabilitation. We don't know how to take the story further. We've decided to report this as a phenomena. Having shown that critical illness now affects muscle and fascia, we looked at muscle and bone. So the bone story in critical illness is not new. Neil Orford, who I think is a Melbourner, works in Geelong, showed in a retrospective study that female survivors of critical illness have a higher rate of fractures compared to non-critical illness females. And in our own work with the British military, we've shown that muscle mass gains are paralleled by changes in bone volume. So we looked at changes in bone mineralization in these patients on day 1 to day 10 of critical illness. And we found that bone demineralization was again related to the PF ratio, so acute lung injury, and unsurprisingly serum calcium levels. Dividing our patients to those with acute lung injury and those without, we found those with acute lung injury lost 2.8% of their bone mineral density, which is the equivalent fracture risk of 19%. So if you're an acute lung injury, you had a 19% increase in your fracture risk in 10 days compared to someone without acute lung injury. So that's the equivalent of going into space and going into orbit and not doing resistance exercise for a month. This is some work done by Jay, a very good friend, Jay Rowell, very good friend and colleague on the muscle cohort, and we've just submitted this for peer review. Moving away from pathophysiology, I mentioned earlier on we were very keen to develop tools for assessing wasting and recovery. And at the very acute end of muscle wasting, I've discussed some of the use of muscle ultrasound. It turns out that muscle ultrasound is very useful not for looking just at muscle quantity, but muscle quality. On the left-hand side here, you can see a patient on day 1 with normal healthy muscle and their muscle ultrasound, and rectus femoris is delineated by this line, and this is their day 7 biopsy with muscle necrosis. Can I convince you that the image on the right-hand side of rectus femoris is brighter than the image on the left-hand side? Maybe, doesn't come out very well. Well, you can use image analysis software to look at this, and this is what we did. And it turns out that the change in muscle echogenicity is highly predictive of the development of muscle necrosis. The area under the curve is 0.85. This looks likely to us that then muscle ultrasound will be a really useful tool for non-invasively detecting muscle necrosis, which would be great because we can move away from doing muscle biopsies. Now, I worry, and I'm sure you all worry, when someone stands up and says, look at this fantastic tool, please go ahead and use it. I think in critical care we've seen many new tools, many new ideas come back and forth, been shown in one centre and then not been reproduced. So I've been very lucky that I've got friends here in Melbourne, at the University of Melbourne, and Selina Parry has offered me a chance to say some of her unpublished data. And you can see on the left-hand side here is the trajectory we described in our original paper in JAMA, showing muscle wasting over 10 days. And her patients here have the same trajectory we have. We show that echogenicity increased in 50% of our patients, which I think is indicative of muscle necrosis. In her cohort, she found an increase in echogenicity in 50%. So ultrasound was used in a separate group by a separate group of investigators in another continent for another study, and the observations seem to parallel each other, which makes me feel much more confident to say that ultrasound is going to prove to be a very useful tool in looking at muscle wasting and muscle quality. Having talked about the sharp end, we were quite keen to start thinking about the recovery, in the hope that at some stage we'd move on to an interventional study to try and improve muscle mass. And this is some work done by my research associate, Angela McNally. In functional outcomes in critical illness survivors, we've been using the SF-36 as a group, as a community, because we've considered that to be our gold standard. But it's a self-reported questionnaire, it's subjective, and it's subjective from the patient's point of view. And we were not entirely convinced that reflected what we were interested in, which is muscle wasting. And we're very interested in accellometry, so physical activity monitoring. It's an objective endpoint, but it's patient-related. And if you talk to patients and you talk to them about activity, steps, you can engage with a patient. We find that we can engage our patient's interest very quickly. We want to look at the relationship between the two of those, but also in the clinical frailty score, which has sort of been brought to the fore by Sean Bagshaw, who's going to speak next. Which is, again, while a subjective endpoint, it's one removed. It's a clinician subjective endpoint. And so Angela set out to look at the construct validity between these three measures and to see whether accellometry would be something we could use. And this is what we found, that in fact they all correlated very well with each other. So on the left-hand side, the SF-36 physical component correlated really well with daily steps. Daily steps correlated really well with the clinical frailty score, and physical function correlated really well with the clinical frailty score. So it seems likely that we could use any one of these outcome measures to look at our functional outcomes in our survivors. The more important question was what were you interested in? And as I said earlier on, we're very interested in activity. So Angela went on to look at activity in our patients 18 months down the line. And we found that these patients, these are the critical ICU survivors, had greatly reduced physical activity in their daily life and had comparable rates of activity to that of COPD patients. So WHO recommends that you take 10,000 steps a day. If, like our COPD patients and our ICU patients, you take 5,000 steps a day, you're considered to be sedentary. And if you're sedentary, you're at risk of all the public health, non-communicable public health diseases such as hypertension, ischemic heart disease, and type 2 diabetes. One would think, though, that seeing that our patients take 5,000 steps a day, and we're looking towards 10,000, if we looked at an intervention that changed this by 50%, we should be able to power a clinical trial quite easily. Unfortunately, the data are more complex than that. And what we did is we split our patients into those who had no previous chronic diseases prior to intensive care, those who were previously healthy, and those with chronic diseases preceding their critical illness. And unfortunately, or fortunately, there's a huge difference here. So if you were previously well, before you became critically ill, you still had reduced steps compared to a normal patient, normal healthy person. However, that was nothing compared to those patients with chronic disease who then became critically ill, who are walking 2,000 steps a day. And that's even worse than your average COPD patient. So the implication of this slide is that we were to look at functional outcomes and trying to improve them in our critical illness survivors, then we'd have to account for the difference in pre-morbid state. I'd like to say this is entirely my idea, but it wasn't. There's a gentleman called Neil Soney at Chelsea and Westminster Hospital back in London, who used to work here in Australia. He edits those intensive care, and he's given a series of lectures and written articles about this, ARDS, acronyms, and the Pinocchio effect. And Neil argues that the reason that we've failed to deliver effective new therapies for ARDS, so ARDS is an imaginary disease that's been given a name, like Pinocchio, and we've believed it to be real. And the worry is, I think as Neil will put it, is that muscle wasting and functional outcomes is a Cinderella problem, and I hope he's referring to the disease rather than myself. And we have to be very clear that we don't mix these two things up. So in the acute end of the disease, in the first 10 days, what we see is a physiological regression to the mean. So regardless of your chronic disease, your pre-existing states, the reason you came to intensive care, regardless of nutrition, you lose muscle mass dependent on the numbers of organs failed, your PF ratio, and possibly your bicarbonate and age. 18 months down the line in the community, we have to account for significant individual variation. And we'll never really be able to, so what outcome measures and trials we design at the sharp end have to be very, very different from what we do in the community. I have to apologize to the audience, the conveners, and my chairs. I'm told that at ANZICS one is no longer allowed to say that randomized controlled trials fail. Neither of these negative controls, so obviously it's early career things, it's my fault, I apologize. These are neutral rehabilitation trials and exercise interventions. And they've been done by some pretty impressive people and names. So Brian Cuthbertson from Canada, Doug Elliott from Sydney, Linda Dennehy from Melbourne. They have large numbers, 286, 195, 150. It's bigger than most critical care intervention trials. They've used gold standards, and they've failed to show that exercise improves outcomes in critical illness survivors. But I wonder what would have happened if they'd reinterpreted these things with respect to chronic disease and tried to control for inter-individual variation. This is Linda Dennehy's study. And she looked at 6-minute walk test as the primary outcome. And this is a graph of her 6-minute walk test. And there were no differences between the intervention group and the control group at ICU discharge home 3 to 6 and 12 months. So Linda very kindly offered me her raw data, and we're sort of working together on this to see how we can reinterpret it. And I'll reinterpret it, I'll split the data between those with chronic disease, preceding ITU, and those without. To control for individual variation, I've decided to report percentage change from baseline ICU discharge rather than absolute minutes walked. Mervyn Singh is not here, but he would say I've massaged the data. And this is what we've shown. If you were previously healthy and you had an exercise intervention delivered by these investigators, you would have a significantly greater improvement in your 6-minute walk test at 3 months, and that would be sustained at 12 months. If you had pre-existing chronic disease, the benefits of exercise and an exercise rehabilitation program would be significant at 6 months, and that would be maintained at 12 months. This is a retrospective reanalysis of a randomized controlled trial, so I wouldn't want to put my name up to this and say, this is obviously what should have been done, and exercise now works. But we're going to use this to sort of start a discussion of how we should design outcome studies in critical illness survivors. 2015 and 2016 are going to be really busy years for the muscle cohort muscle collaborators. We've got 3 to 4 papers coming out hopefully in the next year. The next set of biological analyses will become online by 2015, 2016. Probably one of the most exciting ones of these would have to be the metabolomic profiling done with Mark McPhail at Imperial College London, and the mathematical modelling work that we're doing in Singapore at the moment with the CSOC Public School of Health. We're just starting some new prospective studies, and I would draw your eyes probably again to the IVC study run by Angela McNally and Danny Baer, which is the intermittent versus continuous feeding trial. And finally, we've been very lucky to grow and have lots of good friends around the world and develop some international collaborations. Muscle UK is no longer Muscle UK because we now have friends around the world who work with us. We just call it the Muscle Collaboration. And while I'm standing here, I hope it's been evident to you that I am just one man in the team. And I have a lot of friends and collaborators who I hope I've listed here, who have helped myself and helped my 3 mentors, Nick Hart, Steve Harridge, and Hugh Montgomery, develop this. Last, I just need to thank the NIHR back in the United Kingdom, which has funded this so far, and ANZICS for inviting me. Thank you very much.